Welcome everybody, and thank you for joining me to for a very quick bite-sized run through the Safeguarding Adult Review thematic learning. So it was thematic learning, looking at two cases in respect of multi-agency responses to suicide, particularly in the context of adults who'd experienced multiple exclusion and multiple disadvantage. By that I mean individuals who had long experiences of, say, for example, poor mental health, poor physical health, substance dependency, abuse or traumatic experiences, homelessness. So lots of the individual things that make it much less make it much less easy for them to keep themselves safe, for them to access services in the way that we would like them to be able to. We know from your local data in Surrey that people who die by suicide usually have complex needs. They often have a disability, either physical or mental, sensory, on top of a history of abuse or previous suicide attempts and serious self-harm. Over 50% of those individuals share their suicidal thoughts with somebody. Often that's family members, or the second most common is a health professional. Surrey Council and the NHS partnership, who together are called Healthy Surrey, have recognised there's no single risk factor to suicide, so prevention isn't owned by a single agency. The strategy, and if you click on the link there, it will take you through to the strategy for suicide prevention, requires agencies and communities to work together with through identification of risk, public health interventions, and high quality evidence-based care. So that evidence-based care we know from national research and your local research, particularly in the context of public health work, but also reviews such as this. We know that the best practice is multi-agency, coordinated and personalised support. By that we mean flexible, relational, trauma-informed, which focuses on rapport building, which looks at positive risk-taking by understanding the person's personal and environmental factors. You're looking to help people not recognize that there may be increased risks of suicidal ideation, but also that they have the skills, the ability, and to distract or to manage those feelings, and then also to know when that might not be the case, where to access support and who to access support, and actually to think about having a good reason for living. One of the things I find in the work that I do around safeguarding reviews or domestic homicide, and now called domestic abuse related reviews, is that actually people are very, very, very capable of managing distress and long-term distress and poor mental health in the context of suicidal ideation. But the loss of hope can be can create dramatic changes in their ability to employ their coping strategies. So helping people recognise and thinking about that positive risk taking is really crucial. And it's something that isn't confined just to mental health secondary services. It does need to be something that, across primary care, across social care, across housing, we're more comfortable and confident to talk to people about. Why does this review matter? Well, we looked at the situation for two individuals who we've called Agatha and Nick. They're not their real names, who died shortly, completed suicide shortly after presenting to A&E in a mental health crisis. Again, I think it's important to stress, I've given a hyperlink there to the SAR, to the Safeguarding Adult Review, which is available for you to read on the Safeguarding Adult Board's website. But it is important to highlight that within that SAR, there is very clear evidence of practitioners working very hard to try and mitigate the risk, and a huge amount of professional care shown to both Nick and Agatha. So it wasn't individual failings, it was systems gaps that made it harder for those practitioners to protect their lives. There is evidence of frontline staff across police, A&E, mental health, housing, the voluntary sector, all trying to raise concerns. But that system is very fragmented, and actually it's incumbent on us as humans, part of that human system, is to follow up and to make sure and to ensure that Agatha and Nick or others in their situation felt cared for and supported. Um, again, I think it's important to quote from the report. So the refuge staff repeatedly raised concerns. Often they didn't get a response. EDT staff did not complete the assessment under the Mental Health Act purely because they couldn't get to, in this instance, Nick in time. And that was not because of a lack of caring. It was because they were busy working with somebody else in equal amounts of crisis. In the meantime, A&E staff worked so carefully to try and hold him within the resource that they had, but it's a busy A&E ward. So again, it's thinking about, and particularly in this review, we looked at actually how do we go upstream? How do we stop it so that actually these crises are not managed each and every time in A&E, in perhaps one of the hardest environments for people to self-regulate, for people to understand and utilize those coping mechanisms that they have. How do we really support that prevention and be built into much earlier support through the system? As part of the review, we worked with frontline practitioners and senior managers, understanding what it felt like to work in these cases, what the systems issues were, and they were really honest, really honest about some of the successes that you've had in Surrey, and why those didn't work for Nick and for Agatha. So, for example, the multi-agency working, they talked about the Surrey Adult Matters programme and how that works really well, how that feels really supportive, not just for the adult at the centre, but actually for the practitioners of that team around the person. But that neither Agatha nor Nick were referred to that programme, despite the fact that they had very high risks. They felt that they want a team around the person approach at a much earlier stage, not only whilst the safeguarding thresholds are met and are there persistently. And they felt that that should be something that could be easily achievable if there was much more coordination and confidence to work with supported housing, refuge staff, so people in the voluntary sector, people who've gone, supporting people through the housing pathway, is as much as people who've been accommodated and housed through the adult social care pathway or are in hospital or through mental health pathways. They talked about the fact that they recognise that housing providers are not mental health or care specialists or care providers, but that they know their clients sometimes, and they know their clients really well sometimes. And so their voice needs to be heard when they talk about a critical change in risk. In Agatha's case, she was residing in a refuge, having suffered domestic abuse, and she became increasingly unwell, and so unwell, in fact, that she became quite paranoid about the care and support she was receiving. And whilst that was understood by some parts of our system, through the police, through the mental health services, it wasn't shared with the refuge workers. And that in itself could have created risks, not just for those workers, but also other women and children that were residing in that accommodation. So really valuing that team around the person is critical. Understanding that they can provide protective factors in the context of suicide prevention, but only if they know about the risks. The housing providers spoke about the fact that their warnings about her deteriorating mental health, her suicidation, were largely dismissed because they didn't have that status as caregivers, care providers, or specialist mental health staff. But their experience was as somebody who was seeing that person day to day and had seen a rapid deterioration. Likewise, Nick's mum could report the same. And so it is crucial to think about that wider support network. Who acts as a protective factor? Who can you bring into that team around the person? Sometimes the joy, the benefit of utilising the Section 42, the Safeguarding Adults pathway, is that actually even you can do that in the context of because it's necessary to protect life, and therefore you have the permission to override consent if it's necessary in the context of protecting life, in the context of safeguarding others, or in the context of wider protection, public protection. And that should never be used arbitrarily. If somebody were to say to Agatha, we're really worried about you right now, is it, we need to talk, not is it okay, but we need to talk to the people that who are seeing you day to day. We're going to just ask them questions. We don't need to share information about you, but we may do if it's necessary to keep you safe. That demonstrates to Agatha not that you don't care about her rights, but actually that you're actively trying to protect them, protect her right to life. As I say there, that as a consequence of that sometimes mismatch of can we, should we, how do we share information? Information sharing was too slow or just didn't happen in this case. The SCARF referrals arrived after 5 p.m. and therefore weren't processed until the next working day because the police officer didn't recognise, and because the presentations to that police officer at that time did not suggest an imminent risk to life. But they didn't have the whole picture, and they never would have had the whole picture because that team around the person wasn't in place earlier on in the process. Any psychiatric liaison did not share collateral information with the refuge staff, as I talked about. Practitioners also talked about that they felt sometimes they were simply shouting into a void when they were trying to escalate concerns. So part of the problem is that it's not always clear how you escalate a concern, who should take the lead in that. For example, if you're working as a worker in a women's refuge, and you know someone's mental health is deteriorating, but they haven't engaged in secondary mental health, do you speak to the GP and escalate your concern to the GP? Should it be to adult social care through the Section 42 pathway? If you think they're likely to turn up into A&E, should it be to the safeguarding lead in the local acute or mental health trust? None of that is easily unpicked. If, like I was when I was 20 and working as a support worker in supported housing, it's impossible to navigate that because every place is different and how everybody wants to work is different. That's why it goes back to that important thing about that best practice being, relational, trauma informed, but also being able to really coordinate that kind of how we take and what we do to escalate and challenge if we need to professional judgments and professional decision making. It doesn't need confrontation. It doesn't mean to undermine other people's professional judgment. It is intended to inform and support. And again, as I say, that team around the person really does support that when they're. We know that workforce pressures can block those legal and clinical responses. There were some really challenging things for practitioners in the context of when and how they either use the Mental Health Act or they use the Mental Capacity Act. And again, just getting the time to pull together or to understand how you pull together a team around the person requires quite a lot of knowledge and skill. So again, thinking about how we can create systems that enable, housing support workers to speak more carefully with social prescribers in GP practices and things like that, so that there is that cross coordination and mutual support to work with somebody with high needs, and particularly where there's a risk of suicide. And that high volume of crisis presentations does inevitably lead to desensitization. There has been huge amounts of research. This is not to say that frontline practitioners are anything other than striving for the best for them, for their clients. But it is hard to work in a high octane environment for long periods of time without becoming somewhat desensitized, and that can lead to compassion fatigue and normalization of risk. Again, thankfully, with all the research, we also know how to overcome that and how to best manage that risk, and that does require reflective spaces. It requires good supervision and good support to staff to enable them to manage those feelings and to manage that in a way that keeps them healthy. I often talk to staff when I'm doing training face to face, talk about when you're on an aeroplane and the stewards say about the oxygen mask, put your own on first before you can help others. It's the same when it comes to providing high, support in high octane environments with high risks kind of situations. You need the self-care in order to manage and that's the reflective space is really critical. What we've said within the report, the senior leaders must prioritise, is to really embed that system-wide team around the person, a mandate and early multi-agency discussions for people who have multiple disadvantage. Those needs are always going to be more complex, purely because an individual is going to find it harder to engage. They're going to find it harder to keep themselves safe. They're going to find it harder to follow their care plan, and therefore you need an understanding about what it is the GP needs to know, what it is the housing support officer can offer, what it is that the family and friends may be able to do, and how we all work together to support that individual feel that there's a reason for living, and that they can employ their techniques. And actually, sometimes it's really helpful to know what those techniques are, but also where it needs to be escalated because those techniques are not working. It's really thinking about getting the system-wide approach, that TAP approach, to be used before the safeguarding becomes a risk. So really early on in the care planning, care delivery stage, and that we have a coordination function. There is a resourced central coordination function for housing, police, A&E, mental health to rapidly convene where there is a high risk in terms of Article 2, the right to protect life, where the suicidal ideation is seen as very high. For Nick's case, for example, it was really understood that actually he shouldn't be left alone in A&E, and whilst the A&E staff were actively looking to bring somebody in to instruct somebody to come in for that shift so that they could sit with them, that takes a little bit of time. And in that time, they brought him closer to the nurses' station so that they could have close eyes on him. They did their best to monitor, given how busy A&Es are, but he slipped away, and sadly took his own life shortly thereafter. So embedding that system-wide approach is crucial. Strengthening the information sharing protocols is crucial, that allows the psychiatric liaison to gather and share the collateral information with housing providers, with refuge providers, ensuring that the SCARF referrals trigger immediate alerts, or that there is a clearer way for out of hours to also have scope to have a look at that. Clarifying responsibilities when adults are out of the area and recently released from prison, for example. So in Agatha's case, she had been discharged from prison into the refuge, and so she didn't have the because she couldn't return to her home area because of domestic abuse, and so she didn't have the community support networks that she needed in Surrey, or that she could have had if she was from Surrey, and that increased her risk. The other thing that we thought needed happening was to clarify the roles of housing as third sector providers. So being clear about what housing support can and cannot do, ensure that the concerns that they raise about risk are weighted equally with statutory partnerships. Really thinking about actually ensuring that they're included within the contingency planning for people at high risk. And then in the context of fixing the legal framework, I'm not asking for legislative changes at all, but really helping staff practitioners to understand when to use the Mental Health Act versus when to use emergency powers under Section 4B of the Mental Capacity Act, how to manage A&E in A&E when you cannot use Section 4 or Section 5 of the Mental Health Act because those powers don't apply in that setting. And also how to escalate if there are no beds, if there are no registered mental health nurses available at that time. All of these things need a system response rather than having to be managed at a crisis level on at any given day or evening or weekend in A&E. And then thinking about how we build workforce capacity and reflective practice. create that. See, leaders need to create protective time for reflective supervision. They need to provide training on trauma-informed care, suicide risk formulations, and then monitor for compassion fatigue and the normalisation of risk. Chatting to staff, talking to each other about how did that feel, actually, how do you cope in those sorts of situations? How do you make sure that that's not impacting on your own well-being is really critical, and just and not something that should be, it's your oxygen mask. Use it, please. Um, we we are pleased that the SAB partners accepted the findings and all the recommendations. We built the recommendations specifically to complement the other safeguarding adult reviews that have been undertaken before. So when we talked about so we talked about the need for contingency planning guidance that's built on the SAR. We've talked about the expansion of the team around the person, which builds on Peter's SAR. We talked about better coordination for missing persons at risk of suicide, learning from Louise and the LSR, and the improved responses for coexisting mental health and substance misuse from the Zara SAR. Trauma-informed approaches were also something that was identified as necessary in both Laura and the Tracy SARs. So all of this has been something that you see on far too frequent, sadly, a basis in Surrey, and this is why it's such a critical, important thing for people to take forward. So the recommendations talk about frontline practitioners, recognising that frontline practitioners across statutory, provider, third sectors want to safeguard people at risk of suicide. And so the system must be built to support that, and with clearer pathways, with rapid multi-agency coordination, with stronger information sharing processes, with legal clarity, and clear escalations, not just about by that I don't just mean escalations where you have professional conflict. I mean escalations because somebody's needs, risks are escalating. So do you know when this is something that you can, safely ensure that you try and avoid a hospital admission, or is it something where early intervention might be supportive and helpful, or is it a 999 call because that person is at critical risk? Likewise, if somebody goes missing and you think they're at critical risk, imminent risk because of suicide, is that information passed safely and quickly to the police to allow for them to have their maximum response? Right care, right person has not changed that response, provided the risk is imminent. And that is clearly communicated. And then really seriously thinking about the workforce support, as I've talked about already. So making, for you guys at frontline, for your senior leaders, because they all need that workforce support too, making use of that organisational support. Professional safe care, as they say, is such an important component of being able to effectively safeguard adults. I hope that's been of interest. I hope that's been really helpful. There are lots of really useful information available both on the Safeguarding Adults Board website and on Healthy Surrey website, particularly in the context of, how to safety plan for somebody who might have suicidal ideation. All of these things are very, are readily available, and I would urge you to, if you don't feel confident and comfortable in this area, to spend a bit of time looking at it, and because, as I say, it doesn't take much to give people hope, and it's an area of increasing understandable distress for professionals, for families, for the individuals themselves, and therefore being more comfortable and confident about how you respond when somebody says they feel suicidal is really critical. Good luck in the work that you do. Thank you for the work that you do, and thank you for listening to this. Take good care now.